Hello everyone. So today the topic I shall discuss with you is cell injury. So before the uh, types of injury, let me tell you what are the causes of injury. So what are the causes of cell injury? If a question is asked, which is the most commonest cause of cell injury? This is the answer: hypoxia. Now hypoxia can happen due to many conditions, like somebody has ischemic heart disease, okay, or anemia, anything. But hypoxia is the most commonest cause of cell injury. So this is your first question. Okay, other causes are there. Now next topic is response: how the cell responds to an injury. So there are three ways a cell can respond: adaptation, reversible injury, irreversible injury. So this is in response to stress. When there is a stress, it can lead to adaptation. If the stress is too much, it will cause cell injury, either reversible or irreversible injury. So the causes of cell injury, first question, most common is hypoxia. And what is the response to stress? What is the cell's response to stress? It is adaptation, reversible injury, irreversible injury. So adaptation is obviously reversible, but how adaptation differs from reversible injury? That is the first question. How adaptation differs from reversible injury, because they are both reversible. So in adaptation, the cell continue to function. In cell injury, that is both reversible and irreversible injury, there is impairment of cells function. In reversible injury, there is just impairment of the cell function, and in case of irreversible injury, there is cell death. So impairment of cell function or cell death. Cell death, irreversible. Impairment of function, this is reversible injury. And adaptation, there is no impairment of cell function. There is no impairment of cell function. The cell continue to function. So this is the difference from adaptation. This is the difference of adaptation versus reversible versus irreversible cell injury. Now what are the types of adaptation? Adaptation types, we know: hypertrophy, I'll write in short: hypertrophy, hyperplasia, atrophy, metaplasia. We know this. Now the thing is, hypertrophy, hyperplasia, atrophy, metaplasia. Hypertrophy, there is increase in the cell size. Hyperplasia, increase in the number. Atrophy, decrease in the cell size. So atrophy means decrease in the cell size, not death. Atrophy is not decrease in number, clear? Because it is adaptation. The cell is not dying, so it cannot be decrease in number. It is only decrease in the cell size. It is only decrease in the cell size because it comes under adaptation. So there is only decrease in the cell size. Metaplasia means obviously it's a replacement of one cell type to another cell type, but it is a reversible replacement, like columnar to squamous, columnar to squamous. C for columnar, S for squamous. Columnar to squamous epithelium. This happens in the respiratory lining. I'll write in short: columnar to squamous in respiratory lining due to smoking. This is metaplasia. And adaptation can be of two types. So we're talking about adaptation, which is the first response to stress. Adaptation of two types: physio, pathological. Physiological adaptation example is pregnancy. In this, there is enlargement of the uterus due to enlargement of UT, short uterus. Enlargement of uterus due to what? Hypertrophy plus hyperplasia. There is both hypertrophy plus hyperplasia. Okay. Pathological, it is BPH, benign prostatic hyperplasia. It is hyperplasia, not hypertrophy. It is hyperplasia that leads to enlargement of the cells, enlargement of the prostate. People call it benign prostatic hypertrophy, but this is wrong. It is just hyperplasia. Okay, it is hyperplasia of both epithelial cell and stromal cells. So both the epithelial and stromal cells of prostate undergo hyperplasia. Okay, predominantly around the periurethral zone. So suppose this is the prostate, this is the urethra passing. This zone, which is around the urethra, this periurethral zone. In this periurethral zone, both epithelium and the stromal cells undergo which thing? Only and only hyperplasia, not hypertrophy. Why? The pathology is due to increased dihydrotestosterone activity that happens with elderly men over 50 years of age. It affects predominantly the periurethral zone, also known as transitional zone. So periurethral zone, also known as the transitional zone, is the site where DHT activity causes the thickening, results into hyperplasia, not hypertrophy. Specifically, not hypertrophy. Remember this, not hypertrophy. Again, coming to metaplasia, what is important to learn in metaplasia? It is the conversion of one cell type to another cell type. Okay, this is not the important thing. This is known by all. What is important here is differentiated. So one differentiated cell becomes another differentiated type of cell. That is metaplasia. So important word is a differentiated cell becomes another differentiated cell type. Okay, now examples. If I give you the examples, example is conversion of columnar to squamous. Where this happens? This happens in the bronchi, B for bronchi, in a patient who is a smoker. Here, the ciliated columnar epithelium becomes stratified squamous epithelium. Ciliated columnar epithelium becomes stratified squamous epithelium. Reverse, squamous to columnar. Where does this happen? Squamous to columnar. This happens in esophagus. So in the esophagus, the stratified squamous epithelium becomes columnar epithelium, but this is not ciliated. So the conversion of stratified squamous epithelium in esophagus happens, and the stratified squamous epithelium becomes a columnar epithelium, not ciliated columnar. It becomes just columnar epithelium. In the esophagus, it becomes just a columnar epithelium, not ciliated columnar epithelium. So this is the intestinal type columnar epithelium. But in the bronchi, the columnar epithelium is ciliated. But where this happens? This happens in a case of Barrett esophagus. So in case of Barrett, Barrett double T. So 7 liter. Barrett's esophagus. This is seen in patient with GERD, chronic reflux. This is important that Barrett esophagus happens from GERD and then Barrett's leads to adenocarcinoma, which is now the most common type of esophageal CA in the developed nations like USA. In the developed nations, adenocarcinoma has crossed squamous cell carcinoma, but in the developing nations like India, in developing nation, squamous cell carcinoma is the most common type of cancer of esophagus, but in the developed nations, adenocarcinoma has become most common carcinoma of the esophagus, and this is due to Barrett's esophagus. So GERD leads to Barrett, then Barrett's leads to adenocarcinoma. Another example of metaplasia is the transitional epithelium of bladder. Transitional epithelium of bladder. This becomes squamous epithelium. So the transitional epithelium of bladder becomes squamous epithelium in case of condition where like there is chronic irritation of the bladder, which is seen with schistosomiasis, and stone. These chronic conditions which can irritate the bladder, and the transitional epithelial lining becomes a squamous epithelial lining in the bladder. Then we have something called conversion of fibrous tissue to bone. We have seen that there is osseous metaplasia. This is known as osseous metaplasia, where fibrous tissue, which is nothing but our connective tissue, where the connective tissue like fibrous tissue becomes a bone. Osseous metaplasia. Example of an osseous metaplasia is your myositis ossificans is the example of osseous metaplasia, where the fibrous tissue of muscle becomes bone. Myositis ossificans. Then another example is osteoma. Osteoma of soft tissue, not bone obviously. Osteoma of soft tissue. Soft tissue में osteoma बन गया. Osteoma developed within soft tissue. Then we have a condition where there is formation of calcification in the lung. Pulmonary ossification. Then we have examples of ossifications of cartilage. Cartilage becoming calcified. Cartilage becoming bone. This is known as chondrometaplasia. Specifically, a type of osseous metaplasia is chondrometaplasia, where the cartilage becomes a bone. Okay, these are examples. Okay, first thing, so I pronounced it wrong. It is not osseous, it is osteous metaplasia. I mispronounced it, sorry. It is osteous metaplasia. Now, chondrometaplasia is a type of osteous metaplasia. So, examples of osteous metaplasia, not osseous, sorry. Osteous metaplasia is myositis ossificans, osteoma of the soft tissue, pulmonary ossification, chondrometaplasia. The example of osteous metaplasia is osteous metaplasia of the endometrium. Osteous metaplasia of endometrium. This is not normal. This is an abnormal finding which happens in conditions where there was a chronic irritation of the endometrium. Chronic irritation, I'll write in short CI. Chronic irritation of endometrium. So there was a chronic irritation of endometrium due to which the inner lining of the uterus, that is endometrium, underwent osteous metaplasia. The symptoms will be having abnormal uterine bleeding. Now, what is the difference of osteous metaplasia versus heterotropic ossification. Osseous metaplasia versus heterotropic ossification. What is the difference between osseous metaplasia versus heterotopic ossification? It's a uh, umbrella term. So osseous metaplasia is like the umbrella, and under this umbrella, so this is osseous metaplasia umbrella, and under this umbrella, if a man is there, so under the umbrella, a smaller subunit is heterotopic ossification. So osseous metaplasia is the bigger term, heterotopic ossification is within osseous metaplasia. So specifically we call something as heterotopic ossification when the trigger for the ossification is a trauma. So a trauma, especially trauma like fracture, dislocation. So a person with trauma or neurogenic cause, when these two are there, then we call it heterotopic ossification. Okay, specifically for trauma and neurogenic cause, when this happens, osseous metaplasia happens, we call this type of osseous metaplasia as heterotopic ossification. Now coming to reversible cell injury, RCI. So we have to study what are the morphologic changes in the cell which has undergone reversible cell injury. So first thing is, so it was hypoxia, but the hypoxia quickly disappeared. Okay, it didn't last for very long, otherwise it would have been an irreversible cell injury. So hypoxia was the most common cause of the trigger, because of which what happened, ATP production decreased, because you need oxygen, which oxygen will because you need ATP to function, and this ATP formation comes from oxygen. So low oxygen means low ATP, low oxygen means low ATP production. Okay, because it is a result of oxidative phosphorylation. We produce ATP from three things: glycolysis, Krebs cycle, and lastly oxidative phosphorylation, which takes place in the inner mitochondrial membrane. From glycolysis we get 2 ATP. From Krebs cycle we get 2 ATP. So 2 ATP from glycolysis, 2 ATP from Krebs cycle, and oxidative phosphorylation, which happens in the inner mitochondrial membrane, will deliver 28 to 32 ATP. So total we have approx 36 ATP, but this is not the correct value, this is just for the understanding. Okay, anyway, when our oxygen went down, ATP production decreased. Now what will happen as ATP production decreased? Oxygen went down, ATP production decreased. When the ATP production decreased, this led to the malfunctioning of the sodium potassium ATPase pump, because it survives on ATP. When this will not function, this pump is responsible for pumping out water, right? Because it pumps out sodium. This is the pump which is responsible for making the cell a bag of potassium. A cell is bag of potassium, so its function is to pump in potassium. Its function is to pump in potassium and pump out sodium. And also, so first function of the ATPase pump is to make the cell a bag of potassium, and second function is to make the cell electronegative. So if you remember these two statements, you will know what is the function of ATPase pump, sodium potassium ATPase pump. It makes the cell Back of potassium, it makes the cell negative. So obviously it pumps out more positive charged ions and pump in less positive charge ion. So it pumps out obviously 3 potassium out. So it has to pump potassium out because it is making the cell a bag of potassium. So it pumps out potassium, and it will pump out more, it will sodium, it is pumping out sodium. So it will pump out more sodium and pump in less potassium, so that the cell becomes electronegative. So it pump in 2 potassium and pump out 3, it pumps in 2 potassium and pumps in 3 sodium. For this pumping of 3 sodium out and 2 potassium in, it requires ATP. And by pumping out 3 sodium, it is also pumping out extra water, because with this extra sodium, the 2 positive charge ions are coming in and 3 positive charge ions are going out. So as a result, more water will get out of cell. So cell is now in a state of normalcy. But when this sodium potassium is pumped, when this sodium potassium is pump fail, there is cell swelling. So in the morphology, you see swelling of the cell in reversible cell injury. This was the cell initially having the nucleus. Now this is the cell. So cell has swollen. What are these? Projection outwards. These are blebs. At the cell, we had endoplasmic reticulum, which was like this. Now the ER has become like this. So the ER has also swollen. Endoplasmic reticulum has also swollen. And on top of the ER, ribosome was attached. Now the ribosomes detached from the endoplasmic reticulum. So blebs, swelling, ER also getting swollen, ribosomes are getting detached. So the rough endoplasmic reticulum becomes a smooth endoplasmic reticulum. The rough endoplasmic reticulum starts to look like a smooth endoplasmic reticulum. So inside the nucleus level, if you see, okay, inside the nucleus level, suppose this is the nucleus. Inside the nucleus, the chromatin was not clumped, but now in this cell, the chromatin will undergo clumping. These chromatins have undergone clumping. So swelling, blebs, ER getting swollen, ribosomes detachment, and clumping of the chromatin. These 5 morphological changes are seen in a patient, are seen in the cell of which has undergone reversible cell injury. Reversible cell injury, if corrected, will get corrected. If it is not corrected, if the condition is allowed to progress, it will undergo irreversible cell injury, that is ultimately will lead to cell death. So if it is an irreversible cell injury, then there is no hope, it is definitely doomed. So there will be always cell death after irreversible cell injury. Let's discuss about the irreversible cell injury. Irreversible cell injury. What are the morphological features of irreversible cell injury? So suppose this is the cell. Okay, let me make a diagram. This is the cell. What will happen in the irreversible cell? What will happen in the irreversible cell injury? There is a defect. So there is loss of membrane integrity. This is the key characteristic of irreversible cell injury. And what will happen? Things will start to leak out. Once they start to leak out, now inside the cell, the mitochondria will stop working. Mitochondria will stop working. So, because everything is going out, something will obviously go in, which was in abundance at the outside. So, what was in abundance in the outside? It was calcium. Calcium will go in. This calcium influx is activator of the degradative enzymes. Next, lysosomes, they will rupture and their content will leak out. Enzymes released from the lysosomes will auto digest the cell. And in the nucleus, so this is the cell, and inside the nucleus of the cell, this is the nucleus, you'll find three changes. We all know the terms pycnosis, karyorexis, and karyolysis. Pycnosis, sort of a pycnosis we saw in the reversible cell injury, which was nothing but the, let me clear it, which was nothing but the condensation of the chromatin material. Condensation of the chromatin material. This is pycnosis. Then next step is karyorexis, which is fragmentation of the nucleus. This is karyorexis. Karyorexis. Rexis means breakdown of the nucleus. So nucleus breaks down. Karyorexis. And karyolysis means the end. Complete dissolution of the nucleus by the enzymes. It may be there may be some chromatin material left, but complete dissolution of the nucleus by the enzymes. So pycnosis is the condensation part, karyolexis is the breakdown part, karyolysis means disappearance of the nucleus. And this irreversible cell injury, so we talked about adaptation. If it is too much stress, it will lead to reversible cell injury. If it is continued stress and the stress is too much, it will become irreversible cell injury, and ultimately irreversible cell injury will lead to cell death. Now the cell death can be mainly two types. So in two ways the cell may die in irreversible cell injury. So two ways of cell death. The two ways of cell death are necrosis and apoptosis. Necrosis is always associated with inflammation. Says there is no inflammation. Clear?